And thank you for staying right till the end for this. Thank you, Dr. Jeremy and Nat, for the introduction, and to APACC for the opportunity to present some of our work in women with HIV. The title of my presentation is Facilitators and Barriers to Mental Health Service Integration in Outpatient HIV Care, Insights from Women Living with HIV in Malaysia. This work is part of a larger study funded by a grant from AMFAR. I have no conflicts of interest to declare for this presentation. Research indicates that women with HIV experience a higher prevalence of mental health disorders compared to their HIV-negative counterparts. The presence of a mental health disorder has been linked to poorer outcomes, including non-adherence to antiretroviral therapy and poor retention in care. Despite that, there is very limited data on mental health and women in HIV, especially within our region. Integrated mental health and HIV services have been proven to have improved outcomes in both conditions. However, such services still remain rare in our settings. So I'd just like to give you a bit of context of what it's like in Malaysia and also in University Malaya Medical Centre, or UMMC, where I work and where this study was conducted. So in Malaysia, government-funded services have both mental health and HIV services available, but they are not integrated. And HIV services are available in both primary care settings as well as in hospital-based settings, whereas mental health services typically are usually in hospital-based settings. In UMMC, we are a tertiary teaching center, so we do have both mental health and ID services, but again, they're not integrated. If I could just bring your attention to the graphic on the slide, I'm not going to go through it in detail, but you can see that for my woman in red, for her to get to the ID clinic to mental health services is a rather convoluted pathway with lots of barriers and hurdles along the way. And it's this complexity that really underscores the need for integrated service delivery, which brings me to the aim of this aspect of the study, which was to explore the facilitators and barriers to integrating mental health screening and linkage to care for women in my center. So for this aspect, we conducted in-depth interviews with 19 women with HIV who are under regular follow-up in our ID clinic. A trained interviewer used a semi-structured interview guide, which was based on the Consolidated Framework for Implementation Research, CIFR, the 2.0 version. Data collected was analyzed using thematic analysis with the aid of the Deduce software. So of the 19 women, 17 were Malaysians, consisting of various races in Malaysia, Malay, Chinese, and Indians, and 2 non-Malaysians. You can see that we have quite an aged population of our women. Their median age is 49 years, and their median years since their diagnosis of HIV is about 10 years, a decade living with it already. I'll be presenting our results in these following sections. So for mental health screening integration, the facilitators, barriers, and recommendations, linkage to care integration, facilitators, barriers, and recommendations, and some unique themes for women that emerged. So let's begin with mental health screening. The facilitators for integrating mental health screening into the HIV clinic included patients' awareness of mental health conditions and their willingness to disclose their mental health status to their ID clinician. A 55-year-old participant shared in the quote on top that if she were asked questions about mental health by her HIV doctor, she would actually feel comforted, and she felt that someone is concerned about her condition. Our women also preferred in-person or face-to-face screening, citing reasons of privacy and a perception of more effective communication. As shared by this 36-year-old, she said, "I can talk. I don't mind about fill up that," referring to questionnaires. But if like someone asked me, maybe I can explain them more well. Women were also agreeable to mental health screening and open to screening by nurses or peer counselors, allowing us to now factor in task shifting when planning our service delivery. However, there are barriers to mental health screening, including a reluctance to engage in digital platforms. But one I want to particularly highlight that was a recurring theme was this hesitancy among our many women to answer mental health screening questions if the questions evoked memories of their HIV diagnosis. And here are quotes from 3 different women from every race who shared similar sentiments. A 45-year-old said, "I don't like being asked so many questions. It makes me feel sad. Asking me how you got this, it makes me feel bad." A 68-year-old said, "If they ask about what's this, that sad thing, I will feel sad." And a 61-year-old said, "I don't like," and clarified the interviewer, "You don't like recalling it?" And she said, "Yes, recalling it. I just want to be free." Now, these responses highlight the need for good communication skills. We need to delicately perform our mental health screening and engage with our patients in a way that makes them feel respected and comfortable. And I do look forward to this capacity building session tomorrow on person-centered communication. For mental health screening, women also expressed a preference for screening by staff possessing non-discriminative and effective communication skills. So moving on to mental health linkage to care integration. So facilitators included women's motivation to feel better and understanding the need to speak to someone on their mental state. They, however, preferred consultations with their ID doctors due to comfort and a trust in confidentiality. As highlighted in this quote, it's a support group. The clinic is actually something like that. It's not just coming in to see doctors for meds, it's a support team. We don't talk to anyone else outside, definitely. And this strengthens our resolve to develop integrated services. Participants also reported that co-location, face-to-face consultations and same-day consultations were preferred and were okay to pay $5 more if needed for the extra services. Significant barriers to mental health linkage to care were there, and the main thing was poor mental health seeking behavior driven by HIV stigma. There was also women who strived to be self-reliant, as shared by a 45-year-old who said that previously she was given a mental health appointment, but she didn't want to go as she felt she could still handle it. There was also limited knowledge on the availability of different treatments for mental health disorders, and these barriers will need to be addressed when planning our services. Recommendations included developing a peer support group and offering flexible engagement timing. There were unique themes for women that emerged, emphasizing the role of patients, providers, and communities in influencing mental health engagement. At the patient level, familial responsibility and the desire for autonomy drove engagement. As this participant shared, "I think of my child. If I don't have children at the time, I just won't follow up either or do checkup. Just wait to die." Providers provide prioritizing timely mental health support and also understanding the evolving need for support was really, really important for our women. As one of our younger participants shared, at the start, yes, but now it's been almost 2 years and I think I've adapted and accepted it. This highlights how we need to tailor our program to the evolving needs of our patients. And at the community level, family support, faith and religion emerge as powerful motivators to engage in mental health care, while cultural stigma, especially among the Indian race, presents a significant barrier. In conclusion, women prefer integrated services despite multiple identified barriers, and it's imperative for us to address these barriers and develop tailored integrated care. Moving forward, we have obtained and are obtaining perspectives from healthcare providers with focus group discussions. We're almost done and hope to have some results to share soon. But ultimately, the goal is to develop a framework to integrate mental health screening and linkage to care within our clinic. I would not be here if not for the support of the Chimera team, including my mentors, Dr. Jeremy, Dr. Kate, especially Prof. Rina, and also Dr. Annette, to the ID team, some of whom are here and back home, but most of all for the courageous women living with HIV for driving this work and giving it purpose. Thank you.
Yeah.